Hi, everybody. I'm Adam Hoffberg. This is the Rocky Mountain Myrick Short Takes on Suicide Prevention podcast. Joining us today is Dr. Craig Bryan. He is a board-certified clinical psychologist and also the executive director of the National Center for Veteran Studies over at the University of Utah. Craig is well known, a recognized expert on military suicide prevention and also an Air Force veteran himself. So welcome, Craig.
Yeah, thanks for having me.
Great. Well, we really appreciate you for joining us. Again, we know that you have a strong background in military mental health and was just hoping you could tell us a little bit about yourself and your time in the service, sort of leading up to what you currently do.
I guess it all started back in graduate school. I was really interested in, suicide and PTSD as long as I can remember, kind of entering into the profession. Now, the idea of joining the military, I'll admit, certainly was not something that was on my radar when I went to graduate school. I don't really come from like a military family as we kind of traditionally think about it. And if you had known me before graduate school, I would have probably been the last person you would have expected to join the military. But it was during graduate school where I was interested in PTSD and suicide. We invaded the invasion of Iraq, occurred during my first year of graduate school. Over the course of the next couple of years, faculty members, mentors, and others involved in my training really encouraged me to look into joining the military, especially David Rudd, who was my mentor. He was a former Army psychologist himself. Really encouraged me to look into it, and so I did. And, I was really intrigued by the possibility. And, at that time, it was around like 2005 when I commissioned. This was when things were getting really, really bad in Iraq, and I think people started realizing that this was a lot bigger than what we had initially planned. And given my interest in PTSD and suicide, that was, kind of for me, joining the military was really a way to kind of get in the trenches to work directly with a group that had a lot of needs. And I wanted to kind of do something that most psychologists really don't have an opportunity to do. And so I ended up joining it. Really wasn't a sense of patriotism or anything like that. It really was kind of designed or intended to help service members and to really get my hands dirty along with them and do what I could to help. And so that kind of started my military career. I served 4 years on active duty and deployed to Iraq in 2009. It was in Iraq that my understanding of PTSD and suicide really, I think, became very real because of working at a hospital, just working with service members there who had been injured, seeing service members who had died by suicide. It really had a very profound effect on my understanding of these issues, and it really solidified my commitment to do everything I could to help service members and veterans in need.
Absolutely. That's a helpful introduction to sort of get a frame of where you're coming from. You mentioned Dr. Rudd. I think for today, what we're going to focus on is one of the commentaries you all wrote together, really trying to understand the fundamental question of why do people die by suicide? While we've made a lot of progress in the field, unfortunately, these rates of suicide have been very resistant to change. You all did some theoretical work conceptualizing ways to understand suicide risk and hopefully inform our work reducing suicides. Can you start off, give us a little background on why you think we need to re-examine why people die by suicide?
Yeah, so the conceptual model that David and I worked on is called fluid vulnerability theory, and David was actually the researcher who sort of coined that term and really first elaborated the core tenets and principles of this approach to understanding suicide. And what's kind of, I think, different about fluid vulnerability theory as compared to other existing models or existing theories of suicide is that the FVT, if I abbreviate FVT, that's what I'm talking about is fluid vulnerability theory. FVT says that suicide risk is inherently a dynamic changing construct, right? So you have, in essence, good days and you have bad days. So some days a suicidal person is really suicidal. Some days they're not very suicidal. And that up and down sort of pattern, that fluctuation in risk is in many ways what actually happens in the process of suicide risk over time. And so if we want to understand why is it that some people become suicidal, and why is it that some individuals transition from suicidal thoughts to suicidal action, where they make an attempt or die by suicide, we have to start to appreciate those time courses. What is it that's changing about the individual? And I don't think, in my opinion, many of the predominant models of suicide right now have really taken that into account, because it's a pretty complex and it's a challenging perspective, and it's a challenging issue to easily integrate into a lot of our models, our research methods, and our data analytics strategies.
You mentioned this idea of folks transitioning from thoughts of suicide. In your paper, there was commentary that, fortunately, a lot of the researchers conflated the idea of having thoughts of suicide as being the same as acting on those thoughts or even dying by suicide. That brings to mind this ideation to action framework that has been proposed by Klonsky and some of his colleagues. Could you go into that a little bit for us?
The kind of the idea behind the ideation to action framework is this notion that suicidal thoughts are different from suicidal behavior. But for many, many years, that a large body of research has just assumed that they were the same thing, even though in many ways the data have always been that we've always known that that's not the case. And so if you look at, for instance, those who think about killing themselves, they have suicidal ideation, we know that over 90% of those individuals who think about killing themselves do not actually try to kill themselves. And so there's a very clear difference. Well, why is that? Why is it that only some people who think about killing themselves actually act upon this thought? Well, what we're starting to find now is that when we really kind of think about ideation, thoughts, intentions as being separate from behaviors and actions, a lot of the risk factors and the variables that we have long believed to be predictive of suicide don't necessarily predict suicide. They predict thinking about suicide. So the elephant on the table in many ways is depression. Interestingly enough, depression correlates, predicts thinking about suicide, but it actually doesn't tell us much about which of those suicidal people are actually going to move on to make a suicide attempt. But we have now for decades said, well, depression's a risk factor for suicide. Now what we're thinking is maybe not. Maybe it's just a risk factor for suicidal thinking, and the only reason it seems to be a risk factor for suicide is because people who die by suicide think about suicide, right? And so we've kind of mixed up, these two different constructs. And part of the reason why we have done that, I think, is because, again, if you take into consideration that 90% of people who think about killing themselves will not kill themselves, well, it's in many ways, from a research perspective, it's easier to study suicidal thinking because there's a lot more people who think about it. And so it's kind of more convenient to study suicidal ideation than it is to study actual suicide behavior. And we kind of play this game where we say, well, they're pretty much the same thing, even though they're not. And so now we're at a point, I think, in our research, it's actually, I think, a critical moment in suicide prevention research where we're starting to say, not only are thoughts and actions different, but how does the person get from thought to action? What's the pathway that they follow? Or probably what's more likely the case, there's multiple pathways. Some people choose option A, some people choose option B, and they're getting from thought to action in different ways, but those pathways can be understood if we take the time to really break them down and try to pursue the pathway itself.
Yeah, thank you. That's very helpful. And again, I think it is a shift in thinking about how we study suicide and how we ultimately prevent suicide by looking at these different pathways that individuals may experience to transition from these thoughts to making an attempt, and how using this model can inform our suicide prevention efforts. One sort of a metaphor that I like to use is, to kind of get at the notion of pathways from thought to action, or to use kind of these images that many of us are more familiar with. And in the paper that you're referencing, I kind of use this notion of, if you're in a busy city, if you're like in New York City, you're at your hotel, but you want to get to
some other building, you want to get to the Empire State Building because that's what you're going to do for the day. So you're going to take a cab to get from point A to point B. Well, the Empire State Building is different from the hotel, even though both of them are located within New York City, right? And if we want to know where you are you at one building or the other, in order to kind of make a best guess or a probability statement or an estimate of where you are at any given time, we have to kind of know what is all of the pathways that exist between the hotel and the Empire State Building. And if you know that there's construction going on, if you know that there's traffic, if you know that there are one-way streets in certain configurations, you can actually eliminate a lot of the options. And you can increasingly get more and more precise in figuring out how is your cabbie going to take you from that hotel to the Empire State Building. Okay? And that's in many ways how I kind of think about the fluid vulnerability theory, as well as the ideation to action framework more generally, is this notion of eliminating options so that we can hopefully reduce this question to just a few pathways, which increases the likelihood that we would be able to identify where is someone at, how close are they to acting upon suicidal thoughts. And then we could potentially make a much, much more effective intervention.
That is helpful, thinking about how everyone's unique. There's no one way that someone may go from thoughts to action, and there's these dynamic ways that folks may go. You already touched on this, but I think it's important to talk a little bit more about the dynamic nature of suicide risk. That risk fluctuates over time. Can you go into that a bit?
Absolutely. So part of one of the other kind of central assumptions of the fluid vulnerability theory is that suicide risk is conceptualized along two different dimensions. Now, if you read some of the original writings of David Rudd and even some of my writings from several years ago, you'll see that we use terms like baseline risk versus acute risk. In the article that you're referencing and in some of my more recent work, I'm kind of shifting the language a little bit to more stable versus dynamic dimensions of risk. And what I mean is this. So in fluid vulnerability theory, what this argues is that suicide risk has certain chronic, stable, persisting dimensions. So there are some people, for instance, who are just more likely, they're just kind of predisposed to becoming suicidal, right? And that risk will endure over time. If, for instance, you have a persistent mental illness, whether that's schizophrenia, recurrent major depressive disorder, bipolar disorder, so on and so forth, that is a condition that has known chronic aspect, and it will continue to persist over time. So the risk associated with those particular diagnoses will continue for months, years over time, right? Now, there's also this dynamic or this acute dimension of risk. And this reflects day-to-day changes or even moment-to-moment or hour-to-hour changes where some nights you get a good night's sleep, other nights you don't. Some days your mood is better than it is on other days. And even within the course of the day, things happen to us that influence our risk and protective factors. So if I wake up in the morning and after a restless night of sleep, I wake up and I'm not feeling very good, right? So then, I take a shower, I get dressed, I get my cup of coffee, and on the drive in to work, I spill the coffee on my shirt. So now my mood is even worse than it was before. When I get to work, and then when I get to work, my boss, says, you did a great job on this report. It's fantastic. We're going to give you an award or a prize or recognize you in some way. Well, that makes my mood go up, right? And then I might have an argument with a coworker and my mood goes back down. But then I get home, I see my spouse, very, supportive. They listen to me. We have a good dinner, and now my mood goes back up. And so even within the course of the day, the things that I experience fluctuate. And that really kind of captures this dynamic, acute aspect of suicide risk. And so we have to consider both the stable baseline aspects of suicide risk along with these more dynamic, acute natured aspects of risk. because it's a combination of who we are as individuals combined with the things that we experience on a day-to-day basis that really help us to understand why it is that some people become suicidal and whereas others do not.
Again, that's super helpful, breaking it down and thinking about risk as both static and dynamic. And how can that help us with interventions? Or, when we think about static risk factors, some of these things we may not be able to change. But dynamic, you start to see maybe we can have things targeted at these processes that do change. Could you talk a little bit more about that?
Yeah, absolutely. I think the clearest example, from a clinical perspective on how stable versus dynamic aspects of risk really make a difference are, I think the clearest example of how dynamic versus stable aspects of suicide risk matter from a treatment and intervention perspective is perhaps best demonstrated by, cases or individuals who have made repeated suicide attempts, maybe 2, 3, or more suicide attempts during their life. These individuals tend to experience suicide as a chronic recurrent issue, and many of them will kind of talk about how they just constantly think about suicide. So it's just always sort of present. It pops in and out of their mind. So here is in many ways a person with an elevated baseline risk, or they have lots of stability in suicide risk over time. Well, if such an individual were to come to me as a psychologist for treatment, and I were to say, okay, let's set as a treatment goal to not think about suicide, and that's going to be our outcome. Don't think about suicide anymore. That's probably not a realistic outcome. If someone who has been thinking about suicide, it pops in and out of their mind dozens of times a day or more, and this has been going on for 20 years of their life, why would I expect that all of a sudden they're not going to think about suicide anymore, even if I provide good care? Well, that can then create a situation where I'm, in essence, building an unattainable goal, which then just makes the person feel worse, because oftentimes they say, well, gosh, I can't even stop thinking about it. Even in treatment, nothing helps. I'm a hopeless person. There's something wrong with me. And now I've actually just made things worse as a clinician, even though I didn't intend. So with an individual such as this, oftentimes in treatment, when I'm working with them, we really talk about how thoughts are different from actions. You can think about suicide a lot, but it doesn't mean you have to act upon the thoughts. And so it's really sort of in many ways embracing who they are, these sort of stable properties of suicide risk, and working within those parameters and saying that there are just some things that you will continue to experience over the course of your life, and that's okay. It's uncomfortable, maybe it's unfortunate, but it's okay. And let's talk about what you can do to live the life that you want to live despite some of these chronic, stable, persisting nuisances and sources of pain and suffering that it sounds like maybe you're going to have to contend with for quite a while.
Right. And what about also, for example, demographic factors? When we look at, they tell us that certain things are risk factors, like certain ethnicity, being white, being male. These are things we clearly cannot change. And, how does this model help us look beyond some of those other sorts of stable risk factors?
So what the model will do is it'll look at things like gender or race. Of course, it's not the gender or the race that is causing suicide, but it's a correlate. And the question then that fluid vulnerability theory would ask is, well, what is it about those variables? What is it about being male that you're 4 times more likely to die by suicide than if you're female? What is it about being Caucasian that increases the likelihood that you're going to die by suicide relative to racial or ethnic minority groups? And this has informed a lot of our research. We found, for instance, in one study that we published a couple years ago, that for men, agitation is a much more pernicious risk factor for suicidal behavior than it is for women. And so we know agitation as a whole is something sort of not good. increases risk for suicide. It's very uncomfortable, really kind of compels people to act in ways to get rid of this discomfort. And for whatever reason, for men, it's sort of experienced as much, much more uncomfortable, and it's much riskier. And so without fluid vulnerability theory, we wouldn't necessarily know to kind of think about how would this stable, unchanging demographic factor influence something that's much more dynamic in nature. And it's been able to lead us to some really interesting, I think, answers about suicide that previously seemed kind of mysterious or unknown.
One of the other points you really drive home in this commentary is thinking about risk over time. So, and this, again, relates back to the dynamic nature, but the idea that even if we can identify an individual who is going to transition from thoughts to suicide, when is that going to happen? And, for example, when would they go on to make that attempt? And you use a great example of a guy named Jim, and again, you touched a little bit about this traffic pattern going through the state, but could you go into it, using a hypothetical patient and thinking about how we might look at this risk?
In the article, and I've done this subsequently in many presentations, I sort of talk about this hypothetical guy named Jim who dies by suicide on Monday. The traditional way that we have approached Jim's death is we ask the question, why did Jim die by suicide? Because we ask that question, that leads us to start looking for risk factors. Well, he had depression, he was abusing alcohol, there were relationship problems, he was male, all these sorts of things. He owned a firearm, all that kind of stuff. And that has kind of been the general approach that we've taken. And what I argued in this article is that, well, question, when we ask, why did Jim die by suicide, that's actually not the question that most of us really, really want to ask. The actual question we're asking is, why did Jim die by suicide on Monday? And by implication, what this means is, why didn't he die on Sunday? And the reason why I say this is a critical nuance to the question is that if we were to go through that risk factor profile, the traditional way of understanding why Jim died, we would find that he was depressed on Sunday. He also was abusing alcohol on Sunday. And he was still a man on Sunday. And in fact, many of these risk factors were not only present the day before he died, in many cases they were there the week before they died, or maybe the month before they died. And so what was unique about that particular Monday on that particular month in that particular year, that was the day that Jim transitioned from thought to action? So something had to have changed during the course of that day, whether from Sunday to Monday, or maybe even, from the moment he woke up to the moment that he died. And so when you think about the questions that we're trying to ask, that's in many ways what we want to know. What happened during very, very short periods of time that in many ways, the day before, the hour before, the week before, things seemed to be okay. We knew there was a problem, but we didn't realize just how bad it was. But then suddenly, there was sort of that straw that broke the camel's back, or he just kind of got pushed a little bit more over the edge than he was able to handle. And that's really where I think, my work with fluid vulnerability theory, that's kind of the angle that I'm taking here. And those are the questions that I'm wanting to ask. And we'll never be able to answer that question, why did Jim die on Monday? What was so special about that day? If we don't take into consideration the fact that things change, sometimes during very, very short windows of time.
Yeah, that really helps frame it in my mind and see how useful this theory could be to actually beginning to predict suicide risk in terms of when it will happen, and then therefore having this approach intervene on this pathway and obviously change the trajectory to prevent a bad outcome such as suicide.
Yeah, I think something else kind of related to this is when you start thinking about sort of the change process itself, again, this is kind of the whole central premise of fluid vulnerability theory. Well, the change process itself doesn't necessarily have to occur in a straight line. And this is, I think, one of the other sort of big things that we need to start doing in suicide research is recognizing the fact that change processes are sometimes nonlinear, they're complex. If you talk to most suicidal individuals, what they describe is sort of their subjective experience leading up to a suicide attempt was not simple. It was not a straight line. It's oftentimes experienced as a roller coaster. It was chaotic. It was up and down. I was left and right. I just felt overwhelmed because things were just sort of all over the place. It was really scattered. And I just kind of got worn out, and I was exhausted by that. And very rarely do, at least in my experience, have I talked with suicidal individuals who say, oh, yeah, it was like this steady, constant upward trajectory. Things just steadily got worse and worse. Usually it was much more of a discontinuous process. Well, what that means is, our traditional methods, some of the basic, research methods that we use, as well as the data analytics strategies that we've used as researchers, they're probably not going to be sufficient because most of the traditional methods are based on the assumption of linear relationships. And I've used kind of images to portray this. There's an image in that article, for instance, where you see these sort of data points are scattered all over the place, where it's like this is the person's suicide risk on a moment-to-moment basis over time. And again, they're up and down. They're, kind of fluctuating as the day passes or as weeks pass by. Well, what we have traditionally done as researchers and scientists is we look at all of these bouncing points and then we draw a nice straight line through. We call it a regression line or an average line. And then all of these points that are kind of higher or lower than that average line, we call that error. We say, well, that's just noise, there's error, but this is the best fitting line that kind of cuts right through the middle of all of these data. Well, kind of what I'm arguing now is that those data points, maybe it's not error, maybe it's not noise, maybe that is the signal. And the pathway really is curved. It's convoluted. It goes to the right, but then it cuts back to the left. And if we don't use methods that allow us to follow the actual path as it occurs, we'll never actually understand the path because we'll never actually be able to walk in the steps of the individual who is following this chaotic, roller coaster experience that leads them up to trying to kill themselves.
Yeah, that really helps me to see that this model takes into account the complexity of suicide and how it is a complex pathway that fluctuates up and down. And as you mentioned, a lot of times it's a before point and an after point, pre-post type of measurement. And, one could see how we would need to take measurements more often, or maybe some type of moment-by-moment response through an app, or just give us some ideas of how research might begin to take this theory into account when actually designing a research study.
Yeah, I think there are actually a number of ways. One of which you kind of alluded to is I think there's a lot of potential for ecological momentary assessment types of studies or experience sampling methodology, where in essence, you send like a text message or a push statement to a person's smartphone, and you ask them some questions. Just say like, right now, what are you thinking? What are you feeling? What's going on, etc. And so you kind of capture data in real time, and potentially at a much higher frequency than what we have traditionally done in research studies, where we have someone come in and fill out a bunch of forms and then we follow up with them months later. Another methodology that I've been using, I've actually got a paper under review right now looking at this, is within the course of psychotherapy, you could repeatedly sample at every single session. It's kind of mind-blowing in many ways, but many mental health clinicians still do not routinely measure outcomes during the course of treatment. So they're not collecting symptom scores, symptom data, all those sorts of things on a session-by-session basis. Well, if we were to do that, even if you're only meeting with someone once a week, that's still, the frequency is much, much better than once every few months. And we've been able to actually show in some of our preliminary work that when you do this, you can actually model within the course of psychotherapy the session-by-session change process and the nonlinear dynamics that occur during psychotherapy actually might be able to predict who is likely to attempt suicide in the future. And that signal, that sort of early alert system, at least in the preliminary work we've done, emerged as early as the third session of psychotherapy. And so here we could potentially be using even very basic, simple, straightforward strategies, just handing a piece of paper to a patient at every single therapy session saying, fill this out, let me know what you're thinking and feeling, and that might be able to serve as a platform for developing sort of alert algorithms within treatment so that the clinician knows, is this person on one pathway towards recovery, or maybe they're on another pathway that eventually leads to suicidal behavior.
Yeah, that's great that there's directions we can take it to improve the research, but there's also clinical implications that it sounds like folks can begin applying to their work with patients essentially right away. In addition to doing more regular assessments throughout the treatment process, what other takeaways for clinicians do you think come out of the IVF theory?
I think the other significant implications really are helping clinicians to recognize that change is dynamic. So we know, for instance, if you look at sort of the research and the mathematics of change processes, okay, and I say mathematics and people might be getting a little anxious right now, but a lot of the ideas that I'm talking about here, we've known about this for centuries. This is like old news in physics and chemistry and biology and math, but we've not applied this very well-established knowledge and principles to psychology and suicide prevention very well. If you kind of look at what we understand about change processes as a whole, it can really help to inform clinicians in a number of ways, and one of which is that if you recognize that change is a nonlinear process, it provides an explanation for why your patient comes in one week and says they're doing okay, then the next week they say they're not okay, then the next week they're okay, then the next week they're not okay, and they kind of bounce back and forth. Now, traditionally, we as clinicians look at this, we say the person's unstable, they're impulsive, they're unpredictable, things aren't going well, and it's because it's not a straight line, right? For us, traditionally, the indication of a person getting better is they start off bad and then they get progressively good. And if they ever have a setback, if they ever shift, kind of take a few steps backwards, well, it's a relapse, it's a recurrence, somehow that's not good. But when you understand the science of nonlinear change processes, you would actually see that in some cases that back and forth that we sometimes see is a representation of the change process itself and might actually reflect progress. And so, we've kind of worked with clinicians, and I've even learned this in my own practice. When that patient comes in and says, I had a really bad week, and their symptom scores have now reversed course, and they usually feel terrible. I screwed up, this isn't working, all this kind of stuff. Well, now that I understand a lot more about nonlinear change processes, what I do is say, no, actually, this is a part of the process. Having a step back doesn't mean that things have failed or it's going to fail. What it actually means is that you're changing and you're shifting to a new way of thinking, a new way of acting and feeling. But every once in a while, you slip back into the old pattern. And that makes sense, right? And we understand this from, trying to change habits and behaviors, trying to not bite your nails, trying to quit smoking. Whatever the change is that we're trying to do, we have these slips into old ways of doing things. The same happens with suicide. And you can be feeling okay, but then slip back into an old way of thinking and behaving. And being able to sit down with the patient and say, no, here's why it's happening. you can now re-elicit hope and get them back to where they need to be to achieve their goals.
Yeah, I really appreciate that. Just want to ask you one closing question before we wrap up, and this goes back to your experience treating PTSD and familiarity working with patients with PTSD. How can we think about PTSD and how it contributes to suicide risk through this frame of the fluid vulnerability model?
So within the fluid vulnerability theory, we have this embedded concept. It's called the suicidal mode. And this is really, in many ways, sort of the structural conceptual model of the fluid vulnerability theory. And it organizes risk and protective factors into these different domains. So you have, behavioral aspects of suicide risk, cognitive, emotional, and physiological aspects of suicide risk. And then we have what's referred to as triggers. These are like the life stressors that we experience in life. And all of these domains, again, they all have stable properties, but they are also dynamic, and so they're constantly influencing each other, right? So if you experience a stressor in life, that might affect your mood, and then when your mood goes down, you start thinking mentally, this sucks, this is never going to get any better, and so then I start drinking, and then when I drink, then I feel guilty about it, and that affects my sleep, and so all of these things are related. Well, when you think of it from that perspective, PTSD cuts across all of these domains of what we refer to as a suicidal mode. So PTSD involves a lot of guilt and shame. Those are sort of the cognitive and the affective aspects of the disorder that we have been able to demonstrate increased risk for suicidal thoughts and behaviors. PTSD involves agitation, insomnia. Well, these are the physiological aspects of the disorder that can increase risk for suicide. We also see emotional numbing, anger, and anxiety. These are the emotional aspects of the suicidal mode. And we oftentimes see avoidance behaviors, whether it's substance abuse or whether it's other forms of coping strategies that behave. Well, so in many ways, PTSD cuts across all these different facets of suicide risk, which is part of the reason why I think it increases vulnerability to suicidal behavior. We also know that PTSD is related to deficits in emotion regulation. So in many ways, when you acquire PTSD, you gradually lose the capacity to manage stress in your life. Well, emotion regulation deficits is one of the underlying stable vulnerabilities that's proposed by fluid vulnerability theory. PTSD also fundamentally changes the person's worldview, their view of themselves, their view of others, and individuals with PTSD struggle to kind of change or reframe those thoughts. This is the second core stable etiological factor that's proposed in fluid vulnerability theory, this underlying deficit in being able to reappraise one's beliefs. And then the third core vulnerability that's proposed in fluid vulnerability theory is problem-solving deficit. So a difficulty in generating options and solutions to the problems one faces and then selecting one that works. We see that in PTSD as well. Individuals with PTSD, because they are inclined towards avoidance-related coping strategies, they're not as effective at selecting approach-based coping strategies that oftentimes are more effective in resolving problems and situations in life. And so in many ways, PTSD, and this is why, interestingly enough, I would argue PTSD is one of the few psychiatric conditions that actually differentiates who thinks about suicide from who acts upon suicidal thoughts. And I really think it's because it's sort of this multimodal disorder that cuts across multiple domains of risk and specifically targets many of the stable underlying mechanisms that we've hypothesized in the fluid vulnerability.
Yeah, thanks for that. And it sounds like there's a whole lot more to dive into there. Hopefully we can have you back to go into some more about that and perhaps some of the treatment approaches that work best. For today, I think you covered it quite well. Any final thoughts before we close out?
No, I don't think so. I think I guess maybe my closing thought would be that, I think as I alluded to before, this is a really critical time in suicide prevention research. I think there are a lot of new ways of thinking about suicide that are really advancing us much, much more rapidly than, we've made gains over the past 50 or 60 years. And I think we'll continue to make significant progress. I think it's why we have now identified effective treatments for preventing suicidal behaviors, and will, I think, continue to make improvements upon those interventions and strategies and get better and better at this as a result.
Excellent. Well, thanks again for your time today, Craig. Really shed some light on emerging work in suicide prevention theory and contributing towards prevention efforts across the field. Thanks again for everything that you're doing. And that'll be it for today, everybody, for the Short Takes podcast. We appreciate everybody for listening. You can certainly learn more about Dr. Bryan, the work he's doing with National Center for Veteran Studies, and all these links will accompany the podcast. Please feel free to reach out to us with comments, questions, any thoughts you have about this theory or the work going on. We'd love to hear from you. Till next time, this has been the Suicide Prevention Podcast.